Good morning to everyone. I'm Dr. Laura Lacher, and welcome to Medical Grand Rounds. I'm super excited for the 2023-24 season, which just got kicked off last week. I'm here in Southern Auditorium at Providence St. Vincent Medical Center. And just a few reminders and logistics before we get into introductions for the day. First off, next week's speaker will be Dr. James Laidler, who will be giving a talk on benzodiazepine use disorder. And again, here in Southern Auditorium, we will often be meeting live for Grand Rounds, which is a really exciting development after COVID-19 pandemic. The email invite for each week will always say whether we will be meeting in person or only virtual. And Grand Rounds will always be available on the virtual Teams Live platform. This is a collaboration between Providence St. Vincent and Providence Portland Medical Center. When we have visiting endowed lectureships and visiting speakers, we will do our very best to have that speaker present both here at St. Vincent and then the following day on Wednesday at Providence Portland. You can earn CME credit by being with us here in the live audience or the live virtual, or by watching a recording of the event, and that is available at the same link as the invite. I'll be monitoring the Q&A for those online during the session today, and we'll mostly hold those till the end to ask our speaker as time permits. And now to introduce today's speaker. We are joined by Dr. AJ Singhvi, who is a practicing gastroenterologist with the Oregon Clinic East since 2021, with special interest in disorders of the pancreas and the biliary tract. Dr. Singhvi earned his medical degree and then went on to also complete internal medicine residency at Northwestern University. He then did fellowship in gastroenterology and hepatology at the University of Pittsburgh, and additional fellowship training in advanced endoscopy at University of Michigan. Dr. Singhvi has taken on leadership roles, research, and education in these areas of particular expertise in the pancreas and biliary system. He is a 2023 Portland Top Doctor, and we are so delighted to have him come and share and teach his expertise today. Thanks.
Thanks, Laura, so much for that introduction, and thanks everyone for coming. My name is Ajay Singhvi, and today I want to talk about acute pancreatitis, where we are in 2023. I have nothing to disclose for this talk, and this is a brief outline of my presentation. First, we're going to talk about pancreatitis, the scope of the disease, the burden of illness, and then we're going to talk about early interventions, what works, what doesn't work, and then management of later complications when we can get endoscopically involved, do drainage procedures and such. So, as most of you know, acute pancreatitis is a debilitating condition. In the United States, it's a leading cause of inpatient care among GI conditions. It accounts for more than 275,000 patients hospitalized for acute pancreatitis annually, and its aggregate cost of more than $2.6 billion per year. So it is a very important disease that we need better management strategies for. The incidence of acute pancreatitis ranges from 5 to 30 cases per 100,000, and that incidence has been rising over the past several years. And overall case fatality rate for acute pancreatitis is roughly 5%, and that's expected to be higher in severe acute pancreatitis. So, also, as most of you know, diagnosis is based on two of the following three criteria. So the first is characteristic abdominal pain. That's pain radiating to the back, sometimes associated with nausea and vomiting. The second criteria is a lipase or an amylase that's 3 times the upper limit of normal. And when you're getting transfers from other hospitals, just remember that, because not every lipase is the same. And so not every lipase of 300 will correlate with that being 3 times the upper limit of normal. And then the third criteria is radiographic evidence of pancreatitis on cross-sectional imaging. And I would say that early on, if the diagnosis looks like acute pancreatitis, they're coming in with pain, they have a lipase that's greater than 3 times the upper limit of normal, you don't need the CT scan up front. That CT scan with contrast can cause renal injury, and is probably not going to change your management so much. So I'd rather you get a right upper quadrant ultrasound, look for an etiology for their acute pancreatitis, and get the CT scan once a few days have passed and you know that they're not headed towards renal failure. And the severity of disease is categorized by the revised Atlanta classification, which we're going to get to in just a minute. So first, let's just start with a patient with acute pancreatitis. This was someone that I took care of a few months ago. She was a 25-year-old obese female. She came in with her first episode of acute pancreatitis, and on admission, she was tachycardic, hypotensive, afebrile. She's adding 85% on room air. She was a bit tachypnic. Her exam, she was in quite a bit of tenderness in her abdomen, and her initial labs showed hemoconcentration, normal renal function. Her BUN was elevated at 30, her white count 17,000. Liver chemistries were elevated. Her AST was 81, ALT 300, alkaline phosphatase 123, and total bilirubin of 2. So as you're thinking about this, these are some of the questions that I have. Well, should we perform a CT scan now? Would you admit her to the ICU, or will she be fine on the general medicine floor? What would you recommend for fluid resuscitation? And how would you determine when you've reached goal? Would you give her antibiotics? Would you recommend an ERCP now? And would you offer TPN or tube feeding? So I think it's important to first start with what we know and don't know, or maybe know but don't do. And acute pancreatitis, it's very impressive because what we knew 15 years ago, what we practiced and thought was definitely correct, is probably has completely changed. And so what we knew for certain 15 years ago when I was in medical school was that the Ransom criteria accurately predict outcomes but are impossible to remember. We now know that the multiple scoring systems don't outperform an experienced clinician. We used to think that patients need to be NPO for prolonged periods to rest the pancreas. And now we know that patients can be fed early. We used to think that massive fluid resuscitation prevents progression of severe acute pancreatitis. And we now know that over-aggressive fluid resuscitation leads to worse outcomes. We used to think that TPN improved outcomes. And now we know that TPN is risky and often not needed. We thought that prophylactic antibiotics prevent infected pancreatic necrosis. And we now know that prophylactic antibiotics really don't work. We thought that infected necrosis requires urgent open surgical debridement. We now know that waiting, delayed intervention on infected necrosis allows it to be more walled off and allows for safer, more minimally invasive interventions. We thought that early ERCP improves outcomes in gallstone pancreatitis. And now we know that in the absence of concomitant cholangitis, ERCP really has no benefit. We thought that cholecystectomy for gallstone pancreatitis can be delayed for several weeks without risk. And now we know that cholecystectomy should be performed at the index hospitalization. And we used to think that complete recovery of pancreatic function was the rule. But we now know that a significant proportion of those patients with even mild pancreatitis develop complications of diabetes and exocrine pancreatic insufficiency. Over the past 50 years, we've thought of acute pancreatitis as really having two etiologies, either alcohol or gallstones. And everyone who doesn't have alcohol or gallstones is basically idiopathic. That was what it was categorized for. This is an old study, but this was an epidemiology study from 2002, and it kind of holds true still 20 years later. As people age, whether they're male or female, the amount of idiopathic acute pancreatitis goes up, and that's what the blue bar shows. And so what are these idiopathic causes of acute pancreatitis? So there's quite a broad differential, whether that's missed microlithiasis, missed alcohol use, and I would say those are two very prominent things that are often coming to the differential. Metabolic causes, hypertriglyceridemia, hypercalcemia, drug-induced, so medication-induced pancreatitis is a developing field. Malignancy can cause it, whether that's ductal adenocarcinoma, whether it's an ampullary adeno, or an ampullary carcinoma causing obstruction, an IPMN that's causing main duct obstruction. Autoimmune pancreatitis is now a well-defined etiology of acute pancreatitis. Celiac disease definitely predisposes patients to acute pancreatitis. It's quite controversial whether pancreatic divisum or sphincter of Oddi dysfunction are causes of acute pancreatitis. There's research that's ongoing. And then there's genetics, post-ERCP, and that list is going to grow. And with more trials, we'll have even more etiologies for acute pancreatitis. So hopefully that category of idiopathic will shrink. So how do we classify disease severity? We use the revised Atlanta criteria, and there's really two phases of disease. And it's important to know that these phases exist. There's early phase and late phase because this impacts what complications are going to develop. And so we define the severity based on the persistence of organ failure. So in mild disease, there's no evidence of organ failure, whereas in moderate disease, there is transient organ failure, what we say less than 48 hours. So that's either renal failure, respiratory failure, or circulatory collapse, or evidence of local complications such as pancreatic necrosis. And then in severe, we have persistent, more than 48 hours of organ failure. And when we look at these patients with pancreatitis, they either have early complications or later complications. And early complications, such as a fluid collection, can be either defined as acute pancreatic fluid collection or an acute necrotic collection, which within after 4 weeks, that peripancreatic fluid collection will develop into a pseudocyst, and that necrotic collection will develop into a walled-off pancreatic necrotic collection. So what do these look like? Per the revised Atlanta criteria, you can see that less than 4 weeks, these are super immature. There's no drainable fluid on either of these pictures. But when we get to more than 4 weeks, we start to see a well-defined rim and a capsule, something that we can actually intervene upon. And this is a pseudocyst, and this is an example of a walled-off pancreatic necrotic collection. You can see air in the collection. This might be evidence of infected necrosis. And then some more imaging morphology of acute pancreatitis. You can see this is interstitial pancreatitis. This is a case of mild disease. You see that with contrast and with when you're ordering CTs to really look at the pancreas, you need contrast. You need a venous phase to highlight the pancreas. And you can see that the pancreas is opacifying well. It looks pretty viable. Whereas in necrotizing pancreatitis, this is still early. There's no drainable fluid collection, but the pancreas is a mess. You can't distinguish where the pancreas is. And the reason why these phases of disease are so important is because the causes of death differ based on the stage of disease that you're in. So if you're in the early phase of disease within week 1 to 2, don't think about infected necrosis. That really shouldn't be on your differential. You should be thinking about extra pancreatic complications. So cholangitis, pneumonia, hospital-acquired infections. But whereas weeks 2 to 6 and really beyond 4 weeks, 3-4 weeks, that's when you start to think about complications related to infected necrosis. And for that reason, the AGA, which is one of our major GI societies, that's the American Gastroenterological Association, came out with a guideline in 2018. And this is the most recent guideline in acute pancreatitis. So realize that this is 5 years old. But they recommend that in patients with predicted severe acute pancreatitis and necrotizing pancreatitis, the AGA suggests against the use of prophylactic antibiotics. And it's specifically for this reason, because early on in the disease, there's no reason. We're not suspecting infected necrosis. So prophylactic antibiotics really haven't panned out as far as preventing the development of infected necrosis. And just to harp on this topic a little bit more, the importance of persistent organ failure really impacts mortality. So when there is no evidence of organ failure, it's almost a 0% mortality. Whereas if you have single organ failure, that mortality goes up to 27 to 36%. And when it's multi-organ failure, goes up to 47%. So these are the people that we need to watch out for. These are the people who may need to be in the ICU, but need very aggressive management. So let's go back to our case. And as you recall, she's 25, first episode of acute pancreatitis. She met 3 of 4 SIRS criteria. She was hemoconcentrated, had an elevated BUN. So what kind of fluids should we start her on? Lactated ringers, normal saline. What rate should we give her? Should we bolus her or not bolus her? This has been a topic of active research for the past 25 plus years, and the data is getting better, but it's still not perfect. So this summarizes 7 randomized control trials, kind of looking at different kinds of fluids, different types of resuscitation. There were studies that looked at rapid versus gradual hydration. And they really found no reduction in multi-organ failure, necrosis, or mortality. And 2 randomized control trials actually found that very rapid infusion had increased mortality. I remember when I was in my surgical rotation, we would give people head of starch all the time for acute pancreatitis. They found that plasma expanders, 6% hydroxyethyl starch, head of starch versus normal saline actually resulted in increased multi-organ failure with similar mortality. Lactated ringers. This is dogma in the fields of acute pancreatitis. The reason where lactated ringers comes from is a subgroup analysis from a small study. And what they found was that there was a lower CRP in the subgroup analysis when they compared lactated ringers versus normal saline. So just realize when we say everyone gets lactated ringers, it's based on one single study. And it's really the verdict is out whether normal saline or lactated ringers are truly beneficial. And that's why the guidelines are all over the place. So these are 5 guidelines from different societies. And you can see that this is the American College of Gastro from 2013. This is the American AGA guidelines that we were citing earlier. And these are some other countries' guidelines. And the preferred fluid usually favors lactated ringers, but the most recent AGA guideline really had no recommendation on the type of fluid, but to avoid head of starch. Rate is kind of all over the place. And this most recent guideline said no recommendation based on weak evidence. And the endpoint, that's really what the problem is. It's easy to see a patient who's tachycardic, who has an elevated BUN, who has a hematocrit that's rising. Those are people who are intravascularly depleted. But what do we do once those parameters have improved? How do we assess intravascular volume? We don't have any magical blood test, unfortunately. It's been in the research phases, and many labs have been looked at and really haven't panned out. A year ago, there was this landmark trial that came out in the New England Journal of Medicine, and it looked at aggressive or moderate resuscitation in acute pancreatitis. And it was a randomized control trial of 18 centers, 4 countries, India, Italy, Mexico, and Spain. And patients were randomized to aggressive resuscitation versus moderate fluid resuscitation. So how did they define that? They gave aggressive fluids, that was 20 mils per kilo bolus over 2 hours, and then 3 mils per kilo per hour of fluid resuscitation. And then in their moderate group, they gave 10 mils per kilo bolus, only if they were hypovolemic. And then they gave 1.5 mils per kilo per hour of infusion for fluid resuscitation. And they didn't give any bolus for normal volemia. And their endpoints were to look for severity of acute pancreatitis. And so they were assessed at 12, 24, 48, and 72 hours. Fluid resuscitation was adjusted based on clinical status. Their primary outcome was whether they developed moderate or severe acute pancreatitis, and their safety outcome was fluid overload. So their planned sample was 744 patients, but they did an interim analysis at 248, which actually halted the trial and led to this publication. And when they did their interim analysis, there were 122 patients in the aggressive fluid group and 127 patients in the moderate fluid group. And what they found is that their primary and secondary outcomes, the people who actually developed moderate or severe acute pancreatitis, was no different in the group that received aggressive fluid resuscitation versus moderate fluid resuscitation. But they found that their safety outcomes were significantly different, and that people who were getting aggressively resuscitated had more fluid overload. And that was statistically significant. Percentages were 20.5% in the aggressive fluid resuscitation group versus 6.3% in the moderate fluid resuscitation group. And so I think it's a major undertaking to take on a disease that is difficult and heterogeneous and really it can be challenging to define. I don't think this is the end-all be-all. This trial was halted early. There are some limitations from that. I still think that there are people who would benefit from aggressive fluid resuscitation, but I think the days of giving 400 or 500 cc's per hour blindly for the first 24 hours of acute pancreatitis has fallen out of favor. We should be practicing goal-directed therapy. We should be assessing these patients, and when they're this sick, they should probably be in the ICU and have that strict nursing ratio so that they can be very well monitored. And here are some take-home points of that study, but many questions remain. The type of fluid, whether we give lactated ringers or normal saline. So just a couple of months ago in the American Journal of Gastro, there was a large observational study of 1,000 patients that suggested lactated ringers might be more effective than normal saline to prevent moderate to severe pancreatitis. Remember, this is an observational study. A large randomized control trial is in the works. It's called the Waterland trial. It's probably going to come out in the next couple of years. And I think it'll help clarify this. So I believe these guidelines will change, and hopefully we'll have some consensus in the future. So back to our case. So she had slightly elevated liver enzymes. Recall that she had an AST, ALT, and ALK phos that were up. Her bili was 2. She had an abdominal ultrasound revealing gallstones. Her bile duct was 5 millimeters. She had no evidence of intra or extrahepatic biliary ductal dilatation. So should we get her an ERCP now? Well, the indications for ERCP have really changed, and this is again this AGA guideline from 2018, and they really recommend ERCP urgently when it's gallstone pancreatitis in only 2 situations. Either they have cholangitis or they have obstructive choledocholithiasis that's not improving. Outside of those patients, we shouldn't be offering ERCP. We can actually cause harm. And this was based on 8 randomized control trials that addressed the role of urgent ERCP in gallstone pancreatitis. And when they removed patients with cholangitis and with obstructive choledocholithiasis, they found that mortality, organ failure, pancreatic necrosis, and total necrotizing pancreatitis were no different between patients randomized to urgent ERCP versus or conservative management. And I just want to take a quick segue to another topic, another use of ERCP, and that's on choledocholithiasis. So we often get calls about, hey, how should we risk stratify this patient? Should they go straight to ERCP, or should we do some non-invasive imaging modality first? And this is how we think about these patients. It's based on 2 guidelines that came out from ASGE, that's the American Society of GI Endoscopy. And one of the guidelines came out in 2019. The other was a guideline on management of cholangitis, came out in 2021. So the high-risk people who should go straight to ERCP is if you see a stone on imaging, or if you have a bili that's greater than 4, or a bile duct that's dilated. So that's a bile duct that's greater than 6 millimeters if they have the gallbladder in situ, or a bile duct that's greater than 8 millimeters if they are post-cholecystectomy, or if they have ascending cholangitis. So those patients should go straight to ERCP. And we used to think that in ascending cholangitis, we should just do an ERCP, put a plastic stent, and get out. The teaching now is that we can intervene, we can do a sphincterotomy, we can sweep, and we can try to clear that cholangitis. So the theoretical risk of seeding infection has kind of been debunked. And then intermediate risk are the people who have abnormal liver chemistries without bile duct dilatation, or just bile duct dilatation, or if they're on the older side. So in these situations, we'll recommend endoscopic ultrasound, MRCP, or lap chole with IOC, an intraoperative cholangiogram. And for patients with no criteria and no criteria and just biliary colic, just do a lap chole. No need for the IOC. Our surgeons are great, and they will do an IOC whenever we ask for that. So that's been super helpful. And so in our case, her LFTs actually downtrended over the next several days. We did not offer an ERCP, and she did just fine. So this was actually, she got a CT right at the time of hospitalization, but this was her first CT when she came in. And so when we're looking at this, you can see here's her pancreas. It's highlighting nicely, but there's a lot of fluid around it. It's going to loop back. So it's fluid in a lot of inflammation in the head, but really in the tail, and it extends kind of downward over here. So you can see all of this fluid. So it's early in her course. This was a CT in the first week. We don't know, is she going to develop necrotizing pancreatitis, or is she going to leave the hospital in the next few days? Based on one imaging study, that's kind of the nature of pancreatitis. We need more follow-up. We need more data. So question is, how should we feed her, though? She's having a lot of pain. She's having a lot of nausea and vomiting. So we trialed her on PO. She did not do well with that. So in 2023, where are we with nutrition? And this is another topic that has completely changed and kind of gone full circle. About 20 years ago, we thought, keep everyone NPO until they are off of IV narcotics and they are hungry. Then we start them on clear liquids. Then we advance them to soft foods. Then we advance them to a low-fat diet. And while they are not being fed for a long period of time, let's put them on TPN. We now know that that is the wrong management of these patients. It's important to feed their gut. It improves gut permeability. It reduces bacterial translocation. So we know enteral feeding works and it's superior to TPN. So we used to think that NJ feeds were the end-all be-all, that if you put a feeding tube distal to the pancreas, so beyond the ligament of Treitz, it would help with outcomes. And it did, but this is invasive, requires endoscopy or IR management. So then they started to look at whether a nasoduodenal tube, which is here, so this is the NJ tube and this is the nasoduodenal tube, and they actually did equally well. So then people started to wonder, well, do you need to be post-pyloric? And can you just feed with an NG tube, which anyone can do at the bedside? And these people did almost equally well. So then now the question is, okay, if they're able to tolerate an NG tube, can they just eat by mouth? And that's kind of where we are. In the first 24 hours, our recommendation is that in patients with acute pancreatitis, within the first 24 hours, we recommend oral feeding as tolerated rather than keeping them NPO for prolonged periods of time. And then in patients with acute pancreatitis and the inability to feed orally, the AGA recommends enteral rather than parenteral nutrition. And then as far as the tube feed goes, this is a little bit questionable. You can see this is based on conditional recommendation with low quality of evidence, but they recommend enteral tube feeding with either an NG or a nasoenteral route. And so this is a flow chart. This is an expert panel review, came out in 2020 from the AGA. And it's very similar to that prior recommendation. You address nutrition in the first 24 to 72 hours. If they're able to tolerate PO, give them food. If they're having nausea, vomiting, and ileus or bowel obstruction, they're not going to do well with oral intake. So they're going to need enteral nutrition. So who's going to need an NG tube and who's going to need an NJ? Well, if they have evidence of gastric outlet obstruction, they're having questions of high aspiration risk, those people would probably benefit from an NJ tube placement. But everyone else probably can do just fine with an NG or an nasoduodenal tube. And when they are ready to eat and they're telling you they're hungry, feed them. Now, if you think this is going to be long-term and they're really having a complicated course, we might consider switching these NG or NJ tubes out. If they're tolerating an NG, you might think about switching it to a PEG. But if they're continuing to have gastric outlet obstruction, delayed gastric emptying, and aspiration risk, and they need gastric decompression, you might think about a PEG-J, so a G for venting and a J for distal feeding. But I think the most important takeaway from this slide is there are very, very few patients that we should be offering TPN to, because most of your patients will fit into one of these categories. And so really TPN has fallen out of favor, but it's still unfortunately actively used. Back to our patient, she failed a PO trial, but did fine with nasoduodenal feeds. So you can see that this was a post-pyloric feeding tube. So now we talked about a lot of the literature and the guidelines, and we're going to now talk about the management of pancreatic necrosis. And this is a fluid field. This is going to change completely in the next 15 years. And I'm excited because in 15 years, what we thought that we know for sure now will be different. I guarantee you, because most of these guidelines are based on expert consensus. We don't have large randomized control trials. So we're going to talk about pseudocyst and walled-off pancreatic necrosis. So when we see this, you can see there's a large collection that's developed. This is either a pseudocyst or a walled-off pancreatic necrotic collection. CT doesn't have the detail to tell you if there is necrosis in that collection. You need a T2-weighted MRI or an endoscopic ultrasound to really tell you if there is significant amount of necrosis in the collection. But based on the imaging alone, we don't drain these collections. So we only base it on symptoms. So if they're having intractable abdominal pain, nausea, vomiting to the point that they're having a gastric outlet obstruction, if they look infected, they're having infected necrosis and there's air bubbles in the collection, those are all strong indications to drain. Sometimes these collections can be obstructing the bile duct, causing a biliary obstruction. That's a reason to drain. So those are reasons to consider drainage. So how do we drain them? Well, and just to touch on infected necrosis. So you can see here's the collection and here's a small little air bubble right there. If you can see my mouse, if the patient's septic with a white count, this is probably infected necrosis. If they are not and they're doing just fine, this probably means that the collection has fistulized with the stomach or the small bowel, and there's no that urgency to drain it is probably less than the infected necrosis. And so what are the options for drainage? And I think this is important to understand because this is kind of how our management from a GI perspective has evolved over the past 10 years. So prior to lumen opposing metal stents, these Axios stents that we use, there were a couple of ways of draining things. So if you have this collection, you could put a percutaneous drain through IR, and this is an example of a percutaneous, and there's a pigtail right around it. So the percutaneous modality works well for pseudocysts. That is basically just fluid. There's not much dead pancreas in there. There's no need to remove that necrosis. But the problem is it's painful for the patient. It's a high likelihood of leading to a pancreatic cutaneous fistula. So there are limitations from an IR route. And when there is necrosis, these are small caliber drains. You can try upsizing them, you can lavage them, but at the end of the day, getting rid of that necrosis is going to be very tricky. So then we start thinking about surgical options. And there are many ways of doing surgery on these patients. They can create a surgical cyst gastrostomy where they connect the stomach to the collection. They can bring up a loop of jejunum to the collection to drain it. And then they could do necrosectomy where they're removing the dead pancreas. These are morbid surgeries. The surgeons aren't super excited about doing this. These can lead to complications, long hospital stays. So we've kind of gone away from surgery unless patients are failing IR or GI management. And so prior to 10 years ago, when we were not doing this endoscopically with endoscopic ultrasound or with these lumen opposing metal stents, what we would do is we would find a bulge in the stomach, and you would be doing endoscopy. You'd see this bulge in the stomach. You'd be doing this under fluoro. You'd puncture a hole in this collection, and then you guide a wire in. You do this under fluoro, and then over that wire, you'd put a balloon, you dilate the tract, and then you'd put what are called double pigtail stents. So these double pigtail stents can be placed into that collection to help drain it. The problem with double pigtail stents is the same with the IR route. They're small caliber stents, so very difficult to manage necrotic debris. So then we were thinking, okay, well, we have these other kinds of covered metal stents. They're primarily used for esophageal purposes, but they're bigger in diameter. They can drain this collection, but the problem with it is they're very long. They don't have these struts to help prevent migration, and so they're not opposing to lumens. So these stents could easily migrate fully into the collection or come out into the stomach, which could be disasters. So really the limitations from endoscopic options were we didn't have the right size stent, and we had this cumbersome, lengthy procedure that required the Seldinger approach, which led to more complications. And then endoscopic ultrasound came out, and it became easier to do these procedures. We were able to see the vascular supply, and that's kind of what this picture is looking at. We could use Doppler ultrasound to see what the collection was, but we still didn't have the right stent. So then in around 14 is when we developed, when these lumen opposing metal stents came on the market. And now there are multiple manufacturers of these lumen opposing metal stents. The one that's available in the United States is this Axio stent, which is in picture A. It's a really neat design. It's a short stent with these large dumbbells on either side. One dumbbell that goes on the collection side and one dumbbell that goes on the stomach or duodenal side. And these kind of hug the lumen together because of that short length of the stent. So, and then in 14 also, one more neat creation for this device also came out, which was a cautery tip. So with this device, instead of puncturing that needle and then putting a wire and then dilating the tract, you could do this all in one session because there was a cautery tip. So you could burn a hole, deploy the distal flange, and then deploy the proximal flange without having to do the whole Seldinger technique. It made the procedure easier, less complicated, and less risky. And so what are the criteria for endoscopic drainage? Well, we use endoscopic ultrasound primarily for these cases. We have to make sure that these collections are within a centimeter from the lumen. And this is an example of us measuring how far it is from the stomach or duodenal wall. It's because the stent is 1 centimeter in length. So if it's longer, it will deploy fully into the cyst or into the peritoneum. We have to make sure that they have a mature wall. We want to know what the vasculature looks like. So we usually have either a high quality CT, a pancreas protocol study, an arterial and a venous phase to assess for evidence of a pseudoaneurysm. We want to know about things like that before we go in because our IR colleagues can help with that. If there's a pseudoaneurysm, we want to take care of that because we can cause disastrous bleeding complications by putting an Axios into a patient who has a pseudoaneurysm. And so these official indications from Axios, these came from Boston Scientific, which is the manufacturer. They say a pseudocyst or walled-off necrotic collection that's greater than 6 centimeters, more than 70% fluid content, and the stents can be left in for up to 60 days. And I will tell you, in 2023, we've pushed the envelope. We are draining smaller cysts that are causing symptoms. We're draining cysts that are predominantly necrotic with less fluid content, and we're sometimes leaving them in longer if we need to. It's our conduit to get some of that dead pancreas out, and sometimes that'll take longer than 60 days. So back to our case, we're now asked to perform an EUS cystgastrostomy, and she's having intractable abdominal pain. She's about 4 weeks into her course, but she's still tolerating that enteral feeding with the nasoduodenal tube, but she's still having nausea, vomiting, and unable to tolerate PO. And there's no infected necrosis at this time. So this is what her CT now looks like. And if you see, you can see her feeding tube, and you can see this large collection that's extending all the way down to the left paracolic gutter. So it's a massive collection. It's primarily affected the tail of her pancreas. And we're going to see this again. Here's that collection, and you can see there's a nice wall around it. So at this point, we're thinking, well, we can do endoscopic drainage, but looking at that CT, I can tell you there is no way that we will be able to clear out that collection purely by endoscopic approaches. With that left paracolic gutter collection that's draining, that's going all the way down to her left pelvis, there's no way that we can bring our stent and then with a scope go down and debride that collection. So this will require multimodal therapy. She'll need an IR percutaneous drain going forward. So this was again from that AGA expert review from 2020. They are suggesting that for walled-off pancreatic necrosis, if there's this central component or sufficient size and accessible transmurally, and if that's the case, we can consider EUS-guided placement of a lumen-opposing metal stent for drainage. But if there's this large paracolic gutter extension, we should think about IR drains with aggressive percutaneous drains. And that's actually very helpful. Having that IR drain allows you to flush that drain aggressively. And then you have this Axios stent that's a conduit that whatever comes out, whatever has liquefied can drain out into the stomach, and that'll come out in the patient's stool. And looking at the collection, looks like there's a large amount of solid debris, so she's going to need direct necrosectomy until resolution. So this was her case when we were looking with endoscopic ultrasound. And I know that most of you are not familiar with endoscopic ultrasound, but this is kind of what we're looking at. So anechoic, which is black, refers to fluid in the collection. We're looking for a fluid space. She has a lot of necrosis. This is all necrosis, and only this small area right over here is fluid filled, but she needed some kind of drainage, and we were able to get a stent in. This is the distal flange that we're deploying, and then this is the proximal flange once we've deployed it into the stomach. A lot of fluid came out, and then we put what are called double pigtail catheter stents. So they have a pigtail on one side of the stomach and a pigtail on the other. And these pigtails are used for three purposes. One, when we put this Axio stent in, we have now either a 1.5 centimeter or a 2 centimeter diameter stent that's able to drain contents. But if a solid piece of necrotic debris comes and completely clogs up that stent, that's a problem. That'll lead to infection. So these pigtail stents kind of act as a wick. They don't really drain, but what they do is they prevent that obstruction from occurring. So that's the most important role of these pigtails. The other things are, as that collection starts to collapse, we don't want this metal stent to rub against the wall of that collection. That can lead to bleeding and other complications. So having this plastic stent is a nice buffer for that collection. Can help prevent bleeding. And the other indication for these plastic stents, which is probably the least important, is to anchor this Axio stent in place. The design of these Axio stents with this these dumbbell stents, they won't migrate. It would be exceedingly rare for them to migrate, but I guess these pigtail stents can give you another reassurance. And this is kind of what it looks like on fluoroscopy. So we're here on the stomach side, this is in the collection, and we have the Axios, and it truly looks like a dumbbell stent. And so what do we do after the cystgastrostomy is in? And I will tell you, all of this is expert consensus. This is not based on high quality research. There's no randomized control trial based on this. So I was at a talk at Digestive Disease Week in May of 2023, and it was a panel of experts from different centers. There was Cornell, Columbia, NYU, Hopkins, and a few other places, and they all disagree on their management. Every single person does it a little bit differently. So I'm curious where the guidelines will take us in 10 years from now. But what we recommend at our center is liquid diet for a day after the cystgastrostomy goes in, and then advance the diet. We usually recommend 3 days of antibiotics. We tell patients to avoid PPI and drink Diet Coke 1 to 3 times per day. And this is really to increase the acid content in the stomach. If we increase the acid content in the stomach, potentially this can go into these necrotic collections, help break down the collections, make it easier when we have to go in and remove that dead pancreas and do that necrosectomy. And then we usually recommend CTs to see what things are looking like. 5 to 7 days usually after doing these kinds of procedures. And this CT recommendation is really for walled-off pancreatic necrosis. If they have a pseudocyst, which we'll kind of talk about a little bit later, they don't need a CT so soon. And so some of the complications, these are things that I really want kind of to be on the forefront of your mind is bleeding. It's a big complication, can be catastrophic. So if they are having dropping blood counts, think about a pseudoaneurysm, get imaging early, let us know, let IR know, because these can be devastating complications. If they're infected, it seems like their white count's going up, that stent might be occluded. It might need a necrosectomy, which is removal of that dead pancreas, us going in. And then these complications of a perforation and stent migration, these really happen intraoperatively. And we usually have a pretty good sense of whether that's happened during the case and can let you know afterwards. And then just to touch base on percutaneous drainage modalities, there is still a reason for percutaneous drains. I think this is the most important thing is that it's an interdisciplinary approach, and we should really have GI, surgery, IR all weigh in to see what the best modality of drainage for these collections are. But if there's extension of the collection to the paracolic gutter, extension to the pelvis, lots of necrosis, we would prefer that you go with EUS first, because one it is drained, it makes it very difficult for us to find a window. IR, they can use CT guided or ultrasound guided. So their route of putting these drains does not require fluid quite as much as we do. But we would say that percutaneous monotherapy should not be the standard. It's associated with higher morbidity, higher risk of that fistula from developing a pancreatic cutaneous fistula, and causes patients a lot of discomfort. Now there's been talk in recent years about why do we wait 4 weeks? What's the magic number of 4 weeks? Can we drain these collections a little bit earlier? Well, the teaching was that 4 weeks is when these collections have formed a nice wall, are accessible for us. There have been 6 studies that have come out that looked at draining collections early. And when they say early, it's really 3 to 4 weeks. It's not much earlier than that. And they had 182 patients in the less than 4 weeks and 448 patients in more than 4 weeks. This was a systematic review of those 6 studies. And they looked at clinical success, overall adverse events, and mortality, and really there were no differences in those. So we can consider it, but it is important to note that if we drain these collections early, they usually require more necrosectomies, more procedures, more hospital stay. So these patients had 23 days in the hospital versus in the standard drainage, they required 16 days. And if you're draining collections early, you're more likely to do more interventions. It kind of makes sense. So if we can wait, we like to wait. But if they're infected and you're worried about the patient and you're thinking about pulling the trigger on IR, probably get us involved. And this is kind of what a necrosectomy looks like. It's not a pretty procedure, but we're basically going into this Axios collection and we are pulling out, whether it's with mechanical rat-tooth forceps or snares or baskets. And then sometimes we're lavaging these collections with hydrogen peroxide afterwards, and then we repeat until the cavity is clear. And interval CT imaging can help to see what's going on. And last couple of things I want to touch base on. How do we manage pseudocysts? Are they different from walled-off necrotic collections? And I would say they are completely different. So in a pseudocyst like this one, you can't tell on CT if this is a pseudocyst versus a necrotic collection. But when you do the endoscopic ultrasound, this is what anechoic looks like. It's completely black. There's no debris in it. You know this when you deploy the Axios stent, you know that you'll deploy it, the collection will completely resolve, you'll do a CT in 4 weeks, and then you can just pull the stent out. And this is what it looked like after 4 weeks. The collection had completely collapsed. This is what things looked like at the 4-week mark. And then in my practice, what I do is I pull the Axios stent, trying to leave these double pigtail stents. It gives me a little bit of an insurance that if the collection were to develop again, or there's evidence of a disconnected duct and the pancreas duct is going to reaccumulate this collection, at least they have drainage from these pigtail stents. These stents can be left in for a long period of time. There's really no guideline on when we should remove them. It can be left in for years. Sometimes we think about removing them after about a year if they're really doing well. And just to end on our case, so this is her CT. We have her Axios right over here. You can see the collection has started to decompress. She still has this large amount of collection in her left lower quadrant. And so wrapping up her case, we put a percutaneous drain. She underwent 3 additional EGDs with necrosectomies, had a lap chole during her hospitalization, and this is what her final CT looked like right before discharge. And you can see the collection has really collapsed. It looks very nice now. It's not completely resolved, and that's the nature of this severe disease. She's going to have a long recovery. She's going to still have to build up that nutrition. She's lost a lot of weight from being in the hospital for such a long time. And so I just want to end on some of these key points that we talked about during this talk, just to stress that acute pancreatitis is a debilitating condition. It's helpful to know who are those severe cases, who are going to benefit from more aggressive and more vigilant monitoring. We talked about classification of the severity based on that the revised Atlanta criteria. Etiologies, not just alcohol or gallstones. And then early interventions, prophylactic antibiotics, probably not indicated. do not help to prevent infected necrosis. Fluids. The verdict is out, but probably lactated Ringer's better than normal saline. The exact fluid regimen to give, probably moderate is better than aggressive, but exactly what that is still a bit unclear. And what parameters? Practice goal-directed therapy. ERCP only for cholangitis or choledocholithiasis. Try to do your cholecystectomy during the time of surgery or during that hospitalization. And for nutrition, enteral feeding. So try to feed them by mouth if they're able to tolerate, and if they're not, NJ, nasoduodenal, or NG tubes as opposed to TPN. And then really, we only drain symptomatic collections. And this field of lumen-opposing metal stents has changed the paradigm for how we practice from a GI perspective. So it's very exciting, and I'm excited to see what happens over the next 10 years. And I really want to stress again that acute pancreatitis is a team sport. It starts with the primary care physicians, with the ER hospitalists who are really taking on this disease and seeing them in the first 24, 48, 72 hours. Our ICU colleagues, surgery, get them involved. If you think this patient is going to have a long course, get us involved. IR, we present cases, difficult cases every Thursday morning as a group and make consensus decisions. So nothing is done in silo anymore. And so and this is the last slide. This was something that was developed at the University of Michigan while I was there for my advanced training. And I thought this was embedded into the EMR, and it came up anytime you had the diagnosis of primary diagnosis of acute pancreatitis, this thing called a panc map. And it makes you go through the algorithm of how you manage these patients. And if someone's interested in bioinformatics, I think this would be awesome for the care for these patients, just to help streamline, make it more algorithmic, because really a lot of this is an algorithm. At this point, take any questions. Thanks so much. Yes, she did have an ICU.
Sorry, can you repeat the question, please?
The question was, did the patient end up in the ICU? And yeah, she was in the ICU. She was actually hospitalized in total, I think, for about 90 days. She had a very long course. Many of you probably have seen this CT or many of these CTs, but yeah, she had the real deal.
Does the definition of pseudocyst require previous acute pancreatitis?
Yes. If I would worry about, so when we have these cysts that come up and they don't have any history of acute pancreatitis, I would worry about draining that kind of collection, doing more diagnostics to see exactly where that collection is coming, because not all cysts are pseudocysts. Some of them can be mucinous cysts and other things. So that might be it. If they don't have any prior history of acute pancreatitis and no history of having pain before, I would be a little bit hesitant about draining that with a lumen-opposing metal stent if they're symptomatic. I would first do some diagnostics with an endoscopic ultrasound, sample that fluid to confirm for sure we are dealing with a pseudocyst.
This was great. Thank you. Can you help me think about early what imaging? And I loved that last flow diagram actually sort of supports what I do, which is ultrasound. And it seems like, honestly, there's very little reason for a CT early on, but it often is ordered.
Yeah, I completely agree. And of the centers that I've been at, Michigan was the only place that not everyone had a CT, which I thought was strange at first, because I was used to just looking at CTs, and we like looking at CTs. But honestly, these patients don't need a CT, and you can box their kidneys. So I would recommend an ultrasound. And a week out, if you're questioning what's going on, it's helpful to have that CT. But the first 24, 48 hours are really where you want to protect their kidneys as best as possible. So the real use of imaging is to figure out, is it gallstones or is it not? And that ultrasound will tell you that information.
Great, thanks. I wondered if you could comment at all on your experience with exocrine insufficiency after both complex or maybe even more straightforward acute pancreatitis.
Yeah. Thanks for that question. So we used to think that patients with acute pancreatitis, once they resolve, have no complications. They're done. They will not have diabetes. They will not have exocrine insufficiency. This is kind of been debunked, and a lot of these people, even with mild severity, but really with severe acute pancreatitis, have a significant hit to their pancreas. We used to think that if you have 10% of your pancreatic parenchyma left, just 10%, you would be just fine. But that is really questionable. So if they are having ongoing weight loss, complaining of steatorrhea, think about checking a fecal elastase, sending them to us to look to see if they would benefit. And a lot of these people who have an attack of acute pancreatitis will actually improve. They'll have exocrine pancreatic insufficiency for a period, maybe a year, and then they'll be able to come off enzymes, unlike your chronic pancreatitis patients who probably will never come off of enzymes.
Great, many thanks. And early in your talk, you talked about etiologies of acute pancreatitis. Could you remind us what might raise the pretest probability for autoimmune pancreatitis and an approach to looking for that? When should we worry about it and what to do?
Yeah, so that's a great question. So when we think about autoimmune pancreatitis, there are some imaging criteria that we look for. So, well, what's defined as a sausage-shaped pancreas, so very robust-looking pancreas. But when we're thinking about autoimmune pancreatitis, we're really thinking: is this a mass? So I had a patient who was 49 who had a mass that was called on imaging, but it just didn't fit. He's young. Not to say that all autoimmune pancreatitis patients are young, some of them can be older, but something just doesn't fit right with the diagnosis. And so I would suggest checking that IgG4 level if there is a question, but often in the back of our minds, we're also thinking about malignancy. And so we have to make sure it's not malignant. So in that patient, I had to do an endoscopic ultrasound, take biopsies to really verify that this truly was autoimmune pancreatitis.
Great, many thanks. Any last question in the room?
In my day, in my training, I was always taught that the first three causes of acute pancreatitis or chronic pancreatitis were alcohol, alcohol, and alcohol. Nowhere here has anyone mentioned any quantity of alcohol as causing, where in the range of sort of alcohol imbibing does one run a real risk of acute pancreatitis? And this alcohol use after discharge, very last thing, any quantity.
Yeah.
What is the mechanism of alcohol in acute pancreatitis?
It's more sensitizing the pancreas to the injury. The actual quantity, it's hard to define, but what I would say is females are more predisposed to alcohol, smaller quantities of alcohol than males. If you have so this is really for chronic pancreatitis, and you've developed chronic pancreatitis in a 20-year-old who's drinking, it's not possible that could be secondary to alcohol. There has to be a genetic component because no amount of alcohol can cause chronic pancreatitis at that young of an age. So those are the patients we should be sending genetic panels off to see if they have a genetic mutation, because the double hit that's predisposing. I don't know if I completely answered your question because I don't have a direct quantity of alcohol, but it's a significant amount, and they've been drinking it for a prolonged period of time. We used to think binge drinking, type of alcohol, whether it was wine, beer, liquor, that really doesn't play much of a factor. So it's amount and frequency and for a significant period of time.
Well, I think we are right at the top of the hour at 9 o'clock. Thank you so much, Dr. Singhvi, for your outstanding teaching and your care of these very complex patients.
Thank you.